Okay, I'm back with Dr. Gordon, my favorite hormone optimization expert. I always learn a lot from you every time we talk. And one thing I wanted to start off talking to you about is the connection between brain inflammation and the impact it has on hormonal profiles. So I think that's a really interesting connection. How did you discover this whole thing in your research? Where did this come from?
Well, it's really from the literature that I read. One of my fascinations is the fact that there's so much incredible science out there that no one's reading. So I
Right.
took it as my mission, my goal to go and read as much as I possibly can to become educated on the relationship between inflammation and how it disrupts the chemistry of the brain. And in that process of disrupting the chemistry of the brain, leads to deficiencies or insufficiencies of all the hormones that are regulated by the brain. So, when we start from the causation for the inflammation of the brain, I've talked with you in the past about things like traumatic brain injury versus non-traumatic brain injury. Traumatic brain injury, obviously, there's a physical component to it where someone might be hit on the head in an assault or else slip and fall or doing one of the crazy stunts like in Jackass movie where every one of those people has had major psychiatric problems because of the disruption of their brain chemistry. And then the more subtle things like the non-traumatic brain injuries. How can you have non-traumatic brain injury? Well, the reason is because things that we do, certain medication, exposure to radiation, prolonged surgery, hypoxia, high altitudes, certain medications, drugs, and recreational things that we do, environmental toxins, mercury, lead, going out and shooting guns and having the mercuric chloride from the primer or the lead oxides or lead, whatever, breathing in and disrupting biochemical pathways. We know definitively, especially from my exposure in Fort Bragg, where they have a lot of training with close quarter combat, where they're exposed to their own plumes of toxic materials in their firearms or in their munitions, that it disrupts the ability of DHEA to convert to testosterone and estradiol. And that's by inhibition of the 3-beta hydroxy steroid dehydrogenase, one of the important enzymes that is in the cascade, from cholesterol to pregnenolone to DHEA and down the different pathways. So we need to, in evaluation of our clientele or our patients, we have to look for these as causation for why they might have inflammation. So, okay, regardless of the form, the precipitating causation, they have inflammation in the brain. So what does that inflammation do? Well, in looking at the area, we've seen that inflammation will cause some key enzymes to stop working. And two of my favorite ones are one called tryptophan hydroxylase, the one called tryptophan decarboxylase. What is that all about? Well, tryptophan is an amino acid that we all know about from Thanksgiving. You feel a little fatigued because tryptophan can cause you, feel chilled. It's not all the alcohol you were drinking. It's really the tryptophan. That's the excuse we use, but it's the good 18-year-old scotch that's really doing it. But anyway, so what happens is if you can't convert tryptophan to the next chemical with this hydroxylase, tryptophan hydroxylase, it's called serotonin. So if you can't convert tryptophan to serotonin, you get depressed.
Yeah.
And then serotonin through another enzyme, one primary one, which is tryptophan decarboxylase, it converts serotonin to melatonin. So if you don't have melatonin, you have insomnia. So in 100% of our veterans and probably close to 100% of our civilian population that we see, they have 3 cardinal symptoms: insomnia, depression, and fatigue. And one of the issues with the tryptophan, as tryptophan builds up, it gets converted to, I think it's called neurontic acid or neurolantic acid, which is toxic. So just by inhibiting 2 enzymes, you lead to depression, insomnia, fatigue, and then further damage to neurons in the brain. So that's a change in the biochemistry relative to neurobehavior. In addition, the inflammation, what we found is inflammation causes one of the key cells in the brain. They're called glia, which is a grouping: astrocytes, oligodendrocytes, microglia, not epididymal, but cerebrospinal fluid making cells that are altered. And in the inflammatory cascade, it will cause astrocytes not to produce a chemical that they call PGE3, prostaglandin E2, which helps the brain release gonadotropic releasing hormone, which is the hypothalamus's production of a signal that goes to the pituitary to tell the pituitary to release luteinizing hormone and follicle stimulating hormone. So if you have inflammation, it downregulates the ability of the hypothalamus to turn on luteinizing hormone production. That's why you don't have testosterone production. That's why you don't have estradiol.
Right.
So this inflammation will cause that to happen. So how you fix it?
This may not be related to what you're saying, but what if someone has high luteinizing hormone, high FSH, but they still have really low testosterone? Is TRT the only option for someone like that, or is there another mechanism that can be addressed there?
That's a great question. And the mechanism that came out in a 2018 article out of Denmark, of all places, is the fact that people who are using non-steroidal anti-inflammatory medication, very common over-the-counter, Motrin, ibuprofen, so forth, that what it does is it desensitizes or makes the luteinizing hormone receptors in the gonads with the cells called Leydig cells that are responsible for making testosterone. It makes it insensitive to the luteinizing hormone. Right. So you have lots of luteinizing hormone, as the scenario you just gave, high level of FSH, high level of LH, but you have poor production of testosterone. And most clinicians will look at that and say, aha, this person has primary hypogonadism, where the testicles just aren't working, and never understand or never have the data, the information that it could be due to a medication. Right. That medication is the ibuprofen. So in the literature, in this article, they called it compensatory hypogonadism. What compensatory hypogonadism is when our body perceives that there's a deficiency in a hormone, it upregulates the signal. So testosterone is metered by the hypothalamus. The hypothalamus says, oh, you got plenty of testosterone, plenty of estradiol. We don't need to turn on gonadotropic releasing hormone. We don't need to increase luteinizing hormone or follicle stimulating hormone. But if testosterone and estradiol are low, the hypothalamus says, hey, we need to upregulate the production of testosterone and estradiol by increasing luteinizing hormone. So you see this classical pattern of elevated luteinizing hormone and initially low level of testosterone that under the stimulation of the luteinizing hormone will increase the production of testosterone. And then you'll see where testosterone levels elevate. And that's a compensatory mechanism. Our body compensated for the poor response by increasing the signal. You know, it's like if I'm hearing deficient and you're trying to talk to me and you're talking very lowly, I can't hear what you're saying. So you have to increase the gain of what you're saying so I can hear you, and then I can respond. And that's the same way that the body works. So most docs look at the initially as it being primary hypogonadism, which looks like this compensatory pattern, but they don't know it's compensation because they don't know the mechanism that created it. So certain medication can shut off the recognition of luteinizing hormone by the Leydig cells, luteinizing hormone receptors.
What are some examples of some of the medications? Is this pretty commonly prescribed stuff?
Well, ibuprofen is probably the key one on the list.
Well, and that was someone who takes ibuprofen pretty regularly, or someone who uses
another great question. We have in our veteran population, we have a lot of them that come in with this pattern of compensatory hypogonadism, and they were taking their high dose 800 milligrams 3 times a day of ibuprofen, for 3 months 10 years ago.
Wow.
And then they take it intermittently.
Yeah.
And what happens is it creates a downregulation of the receptors. And so what we've been working on is how to re-up the receptors, and how to do it is by driving the level of luteinizing hormone higher. And what happens is at a critical point, what happens is their system turns on. We call it, pushing through the block. And so we've got 9 guys that we have in a little study that we've been able to give them just, our clomiphene citrate to help increase the production of luteinizing hormone. You can use e-clomiphene also to do the same thing. But what we have available to us readily in our practice that we're doing is the clomiphene citrate, 50 milligrams. And you start them off on 50 milligrams every night for 30 days, monitoring their LH level at the end of the 30 days or 60 days. And then you drop it to every other day or every third day. Our classical protocol for using Clomid in the non-ibuprofen affected individual, which we now know every one of our vets have been on tons of ibuprofen throughout their career. The longer their career, the longer their injuries, the greater their experience of injuries, the greater their exposure to the ibuprofen. Has everybody responded negatively to it? No, not everybody, but the majority that we see have. And we see the pattern. Also, what confounds it or makes it a little bit more complicated is in the compensatory state, you should see high luteinizing hormone and low testosterone. But in the beginning of this dialogue, I acknowledge the fact that inflammation will shut off the brain's ability to turn on luteinizing hormone. So you're looking at the possibility of 2 overlapping scenarios. The one scenario where the astrocytes can't stimulate the hypothalamus to make the gonadotropic releasing hormone to increase luteinizing hormone from one avenue, and the other one is you've got luteinizing hormone being produced, but it's not being recognized by the gonads. So it's an overlapping scenario, and we are working on how to define that, and we basically have to take each part. We have to drop the inflammation, and in dropping the inflammation, we should see a response, and that's what we've seen. We've seen luteinizing hormone going up when we address the inflammation. So 90 days to 180 days to get that inflammation down by using our nutraceutical products, the Brain Care 2 or the Brain Rescue 3 products,
how do those products help address the brain inflammation?
The Brain Care 2 are 6 elements, 6 nutraceutical products, which all influence inflammation in the brain. Some of them by free radicals, like the PQQ, quercetin and glutathione and DHEA work on dropping inflammatory cytokines production through something called NF-kappa B, a combination of gamma tocopherol, which is a form of vitamin E, and N-acetylcysteine work together to drop the inflammatory process of turning on NF-kappa B. We can actually stop the turning on of something called the toll-like 4 receptor, which triggers the production of the transnuclear signaling NF-kappa B that turns on a multitude of inflammatory cytokines. So we have dropping the free radicals, because free radicals turn on the microglia that produce the cascade of inflammatory cytokines, pro-inflammatory cytokines, and then you can manipulate epigenetically some of the other mechanisms that lead to inflammation. So that's what we use for an inflammatory. And it's I think I've shared with you in the past that one of the side effects that we never anticipated was improvement in tinnitus, ringing in the ears.
Oh, wow.
And we've got our military group is 91 vets who were in a survey. They were on our program. And they started telling us their ringing in the ears disappeared. My partner, Andrew Marr, EOD, Explosive Ordnance Demolition, Green Beret, he had significant tinnitus, and it disappeared.
Wow.
100%. We have 6 people out of 91 who had 100% clearing of their tinnitus. And this was brought originally to my attention.
what was was there an average time frame, 90 days? How long did it take for people to?
About 90 to 180 days, but we have some people who are slower in response. And
Right.
I look at their causation. They had more exposure to blast injuries, that and gunfire and, grenades and shoulder-mounted munitions and so forth.
Especially in the music community, there's so many musicians that have tinnitus, and
Right.
it can drive you crazy. You basically have this ringing in your ears 24/7. It'll
Right.
drive you mad.
Yeah, and my daughter Allison, who takes care of the civilian population, we've got 25 civilians in the program, and they're doing better than our military in a shorter period of time. And it makes sense because they were not exposed to the level of aortic nerve trauma as blast trauma does.
Right.
Yeah, they were exposed to loud noise, the car engines, the music, the guitars, the drums, whatever else. So she has, I think, in her population of 25 people, their improvement is 57% improvement in a year. And in my military 91 guys, it is 51.3 or 51.4% improvement. Still significant. I mean, it was a civilian doc, Eric, who basically came to me and said, I've got horrific tinnitus, and anything we can do about it. I said, okay, let's try going on Brain Care 2, Brain Rescue 3 pre-breakfast and Brain Care 2 pre-dinner, and give me a call in 2 weeks. He calls me up in 2 weeks. He says during the day, his tinnitus is in the background. At nighttime, he had a white noise machine. He said occasionally he has nighttime tinnitus, but it's basically gone. I just communicated with him. He moved from California to Dallas, Texas. So in communication with them, and his tinnitus is gone. So when that happened, I said, really? So I started doing a survey. This is late 2020, I believe it was. And the first person I went to was Andrew and said, how's your tinnitus doing? He said, it's gone. I said, when did it disappear? This was in January of 2021. He said, February the year before. And that's when we released our Brain Care 2. He said, February the year before. I said, why didn't you tell me? He said, why didn't you ask? I said, no. Okay. So I started in January of 2021 asking everybody to rate their tinnitus and started getting this feedback of how well. And I had to go back to my literature and look at, ENT and see that technically, according to the literature, if you have ringing of the ears greater than a year, it doesn't disappear. It's chronic. But everyone who had ringing in the ears greater than a year in our military had 51.3% improvement. In my daughter's group, they were 57.4% or whatever it was improvement. So it told me that inflammation was a very important component of their tinnitus.
Right.
Okay. So I learned something new, and that's my goal, is to learn as much as I can before I'm dust.
So the ingredients in Brain Care 3, they can actually pass the blood-brain barrier, because that's always been
correct. And what helps it to pass the blood-brain is the nanoliposomal solution that it's in. Right. It helps it to bypass the gastric acid destruction. It's got DHEA, quercetin, PQQ, CoQ10. What else is in there? DHA, which is one of the carcinoids or omega-3s that specifically helps with anti-inflammation. It upregulates survivin and protectin, two very important proteins that are made in the brain to protect the nerves from inflammation. Studies done on these components, they actually toxed out nerve cells and put in DHA, and it protected them. Yeah. So
I would imagine a big improvement in depression symptoms as well.
Right.
Inflammation has to have a tremendous impact on food.
Well, yeah, as I said, the reason why depression occurs is because the inflammation inhibits the hydroxylase, tryptophan hydroxylase, so you cannot make serotonin.
Right.
And that's why drugs like SSRIs, if you've got someone with inflammation in their brain from blast wave trauma or IED or whatever, that their ability to make serotonin's down. So when you give them a serotonin uptake inhibitor, There's no serotonin to inhibit being
Right.
taken to keep it into the synaptic cleft to do its job
Yeah.
at antidepressant. So that's part of the reason why these medications fail in their job. And another one is the drugs that are used for Alzheimer's disease that are acetylcholinesterase inhibitors. They stop the destruction of acetylcholine. Well, there's no acetylcholine being made because the inflammation generated by the tau protein and the free tangles and the trauma that happened to them that precipitated their onset of dementia of Alzheimer's. We know from NFL studies that guys who have had head trauma or concussion on the field concussion are 19 times at a greater risk than the general population of developing Alzheimer's. And that's because the inflammation that's precipitated by, you can call it whatever you want, CTE, neurotrauma, neuroinflammation, whatever. It all boils down to one thing: inflammation. Causation will be different, but inflammation will always be the same, and the degrees of it. And then the people who 5 years down the road, they leave their sports 5 years down the road and they start developing libido issues, depression, anxiety, insomnia. And the doctors look at them, never ask about their history, and immediately say, okay, you're depressed, take an antidepressant. All they need to do is ask, okay, in your history, did you have any traumas? Yeah, I fell off a roof 2 floors. Oh, yeah, I was an amateur boxer for 5 years. Yeah, I was deployed in Afghanistan and Kuwait and wherever for, 2 years, 3 years, exposed to blast and blah, blah, blah. Or I work in construction. I use a jackhammer. Or I ski, snow ski, water ski, or I play hockey, or whatever, cribbage, I don't know. Or else their parents always hit them upside the head when they did stupid things, whack, So things like that. So what I'm learning is that we've got all these causations, but they all cause the same thing: inflammation. And that should be the focus: neuroinflammation.
I think one that's most distressing that you brought up is environmental toxins, because we
Oh
are
yeah.
bombarded with environmental toxins. I read this Consumer Reports assessment of many chocolate manufacturers on the market.
Oh yeah.
Chocolate brands.
Dark chocolate.
Yeah, dark chocolate. Now there are several dark chocolate brands that I use that were unfortunately on that list, and these are ones that are organic and allegedly come from cleaner sources, but they had ridiculously high levels of lead and other heavy metals, to the point where I just got rid of these because they were so high. It was way beyond a safety threshold.
Right.
That's just one source of things. I mean, all of the food that we eat has some levels of heavy metals, and then we're just breathing into the environment. We're just bombarded with it at all times.
Aluminum has been on the list as, what they spray, and also what's all around us with aluminum dioxide, aluminum, blah, 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 blah.
Yeah.
The pyrophosphates, the dioxin, all the chemical that's around. And, I'm very careful when I plant trees. So when I'm digging, I make sure that I have some kind of filter, because you don't know what kind of crap has been in the soil. This is, ancient soil that's been contaminated with, years of fallout. So, it's very important to, protect yourself. Environmental toxins, there's a lot of endocrine disrupting toxins from, plastic, from,
Right.
from foil packaging, from, food trays, from styrofoam, from everything that we put our food into. That's why we've moved to all glass containers, to avoid anything coming out of the plastic. And then you've got, like what is it called? Gatorades that are in the plastic containers. The more acidic, the more it leaches the BHTs, the DHTs, whatever the letters are for all those chemicals that are associated with it. And these we're ignoring. But if you go online and you start looking up endocrine disruptive chemistry, you'll see a lot of stuff in our environment and our foods, the additives in food to help preserve it, to keep the colors, So we're getting exposed to way more than what we should. And it creates inflammation And when the inflammation is below the neck, the damage occurs to our vascular system and to our organs, creating inflammation. And one of the things that we know about in cardiovascular world is the fact that things like cigarette smoke, either firsthand or secondhand, trans fatty acids, all those inflammatory vegetable nut oils that we're seeing a lot of damage from, the canolas and so forth and so on, that they create inflammation, and that inflammation in our vascular trees creates a stickiness of the lining of the arteries, the intima, and it's an attractant for calcium. So what happens is calcium will start laminating on the arteries, and if you've got a little bend here, it increases the deposition of calcium, leads to atherosclerosis and narrowing of the arteries. So you're at more risk of developing, ischemic heart disease. And one of the things that helps to counter it is DHEA. The Massachusetts Male Aging Study showed how important great levels of DHEA are in protecting you from ischemic heart disease by it stopping that stickiness. And another is vitamin D helps to protect the lining of the arteries. Testosterone helps with the lining of the arteries. So over the course of time, if you have a reduction in the blood flow to the heart, what happens is the heart becomes flaccid, becomes flabby and dilated, because the nutrients that are supposed to go into it, the hormones that are supposed to go to the heart to keep the strength of the heart, the inotropism, the ability of it to have strong contraction, the chronotropism, the timing of contraction from the sinoatrial node, these are influenced. Not having good testosterone level, not having good DHT levels, this will cause a flabby heart. And that's what we're seeing, people dying. And, one of the things that's a curiosity for me is people who are dying from sudden cardiac death because of, a multitude of issues. Is there a clear-cut association with hormonal deficiency? Years ago, there were 3 articles that tried to tell us that testosterone increased the risk for dying of a heart attack. This general statement, it turned out in people with history of having had prior heart attacks and having dysfunction of their heart, that testosterone could push them further. But most of the stories, I think it's 30% improvement in cardiovascular risk. So
let me ask you a question on that. I've had some friends who've used TRT and they said their blood pressure went way up and they retained more water. Is that common? What's the cause of that?
It's not common. It's called a mineral corticoid effect. What happens is, in some people, genetic predisposition, biochemically predisposed, it'll cause sodium chloride to be preferentially reabsorbed from the kidneys, from the loops of Henle. So they'll retain sodium chloride, and with sodium chloride comes a proportionate amount of fluid, water, if you will. So you're one of those people when you start developing pretibial ankle swelling, or suprapubic swelling, or else swelling of the fingers, or puffiness of the face, or chest puffiness. You think it's gynecomastia. It's not. It's no sensation. It could be fluid retention.
Right.
So you have to look at your salt intake. You have to look at these factors, and then a loop diuretic will be a benefit, whether or not it's hydrochlorothiazide with triamterene, or Lasix with triamterene, or something of that nature, or natural diuretics that are out there to help you with diuresis, to help drop the fluid so your blood pressure goes back down. Right. Stress, cortisol will cause blood pressure to go up. Infections, inflammation will disrupt the hypothalamus, which deals with blood pressure, heart rate variability, and all this. We've had veterans who are on a multitude of blood pressure medications, and what? What do you want? What do you want? Huh? You want to join in?
Okay, you have a cat. I was going to say, if you have
we have 2 cats. This is the one that's the needy.
Okay.
This guy needs something. I was going to give him Valium, but I don't use Valium. So he smokes a little weed. He goes and puffs a pipe. Anyway, so now you're going to go. Inflammation affects the hypothalamus, will affect the pancreatic production of insulin. affects the heart rate variability, respiration, blood pressure. So this vet was on 3 medications. When he got started on a program, 3 or 6 months later, he's off all but one of his medications. So he's more controlled. And in some people it takes longer than 90, 180 days to get their chemistry back under control.
Right.
So we don't rush it. We just monitor them and see, the parameters. We make sure their biochemistry is brought back to a healthy level between 25 and 35 years of age. We don't treat numbers, we treat the person. So they might be at a great level of whatever hormone, but they're not feeling the benefits that we'd like them to. So we upregulate it. And we always stay within the parameters between, 50 to 100% of the range. And that's our guide. We have, even in our Alzheimer's, Parkinson's, and multiple sclerosis patients, we've never needed to go above the 100% of the range that the laboratory in our community of medicine talks about. So they might be at 85, 90% of the range.
Right. And do you find with older patients, let's say over 50, that they need to be higher on that range, for example, with testosterone because of maybe less androgen receptor uptake, or is it non-issue?
No.
Okay.
I don't see that pattern. I mean, I consider that they need more, but what we do is we start and at a point and we slowly ascend on the range. And, my goal is 50 to 75th percentile. So it's the second, third quartile is what we like them to be in. And let's say the range for testosterone, free testosterone is the key. It's not total. Total is junk.
Right.
So our lab is 3.8 to 25. So if someone comes in at 4.7, they feel horrible because the benefits of testosterone are sense of well-being, aplomb, assertiveness, competitiveness, memory recall, the ability to learn new things, good sleep, good sex, creativity, visual creativity, auditory creativity, writing creativity, anti-depression, anti-suicide. These are the benefits of having good levels. And that's what we meter, how well they're doing in life, not the numbers. But if they come in at 4.7, we'll slowly bring them up to the 50 percentile, which is 15.4. We'll get them to 15.4. And based on how they feel going up to that level, they'll say, hey, doc, wherever I'm at on my testosterone level, I feel great. And we look at their level and they're 14.8. or they're at 16 or at the 17. That's our endpoint for them, or our plateau. That's where we start from. And a lot of times I'll say to them, okay, you're feeling great now. Let's do this. For the next month, we're going to increase your testosterone by only 10 milligrams. We only make 5 to 10 milligram bumps because I believe that a lot of people are being given too much testosterone. And how do I know they're given too much testosterone? They're on Arimidex or they're on anastrozole.
Right.
I've never used it. And the reason why I've never needed to use it is because, number one, estradiol is very important for men, as you and I spoke about for 2 hours in our past, how important it is for neuroplasticity, for growth hormone production, for blood flow, for protecting the lining of the arteries, the heart, the bones. And we need growth hormone and estradiol to turn on IGF-1, insulin-like growth factor 1 in the liver. You don't have estradiol proportionate to growth hormone, you don't get the IGF-1 being produced. Okay, so it has a lot of benefits. So, we'll meter the patient, and I've shared this with you in the past. We use a score system called MPQ, Monthly Program Questionnaire, which are 25 questions in physiological, physical, and mental condition, and they rate themselves, and we monitor how well they do every month. And these documents become the foundation for our annual report on results. So I just posted the 2021 result. It was smaller population, but they did very well. Yeah. And one of the things that correlating how well they did relative to tinnitus, if they had improvement in tinnitus, there was a proportionate improvement in their overall sense of well-being. If they had overall improvement in their sense of well-being, there was a noted improvement in their tinnitus. So that's the inflammation. And there's a project I'll share with you now. I'll be going to Spain this year. There's a research center in south east Spain, below Granada, I think it is, or Alcante. It's San de Alcante, close to Gibraltar, where they developed a new technique in MRI. It's called DTI MRI, diffusion tension imaging MRI, where they can actually see if the immune cells called microglia, if they're turned on or not. If they're turned on, they make inflammatory chemistry. Okay? They have 3 stages. M0 is their surveillance state. M1 is activated when they're challenged, like head trauma, bacterial, viral infection, bad vaccines. And then there's another, which is M2, which is the anti-inflammatory phenotype of this cell. And it's our immune cells in our brain. So they're able now to dial in and know whether or not it's on or off. So I was talking with the head researcher, doctor there, about doing a test where they have a group of people that are found to be inflamed and then put them onto our protocol, which would be the brain rescue 3 pre-breakfast and the brain care 2 pre-dinner, put them on this for a month and then go back and see how their inflammation is if the cells are still turned on. So that will be a now objective test for doing assessment of how well the products work at turning down their inflammation. We have tests now which are called cytokines, but the problem with the cytokines is you cannot absolutely state that the measurement of serum blood levels of cytokines are coming from the brain because they're made throughout the entire body.
Right.
So we did a study 3-4 years ago in our vets. We paid for this very expensive cytokine testing, and what we found was inconsistency. But inconsistency meaning that their level of cytokines did not always correlate to their symptoms. But one thing we did find was that when the cytokine levels were elevated and we treated them, with our global treatment and their levels went down, they improved and their levels dropped. Okay, but I couldn't say that they came categorically from the brain. It could have come from the low back problem or from their left knee or from their rheumatoid arthritis or their Hashimoto's or whatever. So in being honest about how well we can utilize it, I mean, I'm asked quite frequently, how come I'm not using cytokines for markers in our biomarker panel that we have? And that's the reason why it's inconsistent. So, and it's expensive. If it wasn't so expensive, I'd take the risk of the significance and then try to figure out how we can use it to make it more significant.
Yeah.
But it's just way too much. I think it was 3 months, $35,000. Small population, but I learned a lot from it.
Wow. Going back to just environmental toxins and in particular heavy metals, do you use chelation therapy or anything like that to try to clear out?
Yeah, what we do is we do not a provoked heavy metal assessment. We use a 24-hour urine collection of heavy metals. So we've got 11 heavy metals and 22 nutritional metals because we picked up bipolar with someone who had lithium deficiency. And all we did is replace their lithium. One of the companies has 10 milligram lithium. They
Right.
got better. So we check both, heavy metal. And the chelation are
low on these tests. I mean, I would imagine everyone has high levels of heavy
of
metal.
which? Some of them. We've had cadmium, we've had aluminum, we've had cadmium, aluminum,
There's so much
beryllium. Yeah, not beryllium. Bromine. I think bromine was in it. It's got lithium. I'll send you the papers on it. But my daughter's the one who, she's the one who takes care of the detoxing. And there's
Right.
a multitude of ways to do it. You can do 100% nutritional with sauna and red light, and with certain what is it, the cilantro, you can clove, cilantro. There's a whole bunch of natural ways to do it. And then there's, pharmaceutical approaches for it. But one thing I see is in the pharmaceutical approach, a lot of people get a little ill during the time that they're on it, but after the fact, they're great. They just have to grin and bear it, so to speak.
They're probably getting ill from it being freed up before it's excreted.
Yeah, they're autotoxicity.
Yeah.
They're getting it released. So, my daughter Allison helps with that. She had a company in called Live Natural down in San Diego, where a lot of IV technology they were using, and she was detoxing through IV. But now that she's been up here working with me for 8 years, geez, yeah. So she's become extremely knowledgeable in the neuroendocrine and endocrine of traumatic brain, and then her gut, and that's another area.
Right.
She's been really doing great work with the dysbiosis, the leaky gut, seeing lots of SIBO, lots of H. pylori, lots of leaky gut, and so she's teaching me about her science relative to it. And we've had some really important cases where, a teenager with chronic gut inflammation never getting better, and she puts them onto one of her protocols, and the individual's own doctor says this is the first time his gut measurements have all been normal by putting him on. And some of the things that have helped has been this brain care too, because it's anti-inflammatory on a multitude of levels. I mean, I treat the brain, and we've had a number of people come back saying, hey, were my knees supposed to get better? Was my back supposed to get better? I said, well, I don't talk about the orthopedic stuff because I'm focused on the brain, but it circulates around the entire body. If it drops your inflammatory cytokines, it affects the whole body.
Right.
Yeah.
Right.
Same thing with vitamin D is great stabilizer.
Yeah, that makes sense. I mean, if you're lowering inflammation in the brain, it's going to be lowering inflammation elsewhere. It's not going to just
all over
inflammation in the brain, irrespective of other areas.
Correct. So we, we're trying out certain of our combinations for people with orthopedic, but my greatest responses have been with some of the peptides. Some of the peptides out there, orthopedic peptides like the BPC 157 and the thymosin 4 beta or 500 and the IGF LR3, IGF-1 LR3. These are working extremely well on orthopedic. We've got maybe about 5-6 dozen vets who were given disabilities based on orthopedic injuries while they were deployed and active. They start their own protocols, and their problems disappear from partial rotator cuff tears, from lanubrial tears in the hip, lower back. I think my oldest is a 72-year-old who had chronic hip and low back. Within 3 months, gone.
Goes into the muscle of the pain site, or can it just be subcutaneous, meaning you just inject it into a little bit of fat in the stomach and it just proliferates, it just circulates throughout the body, healing whatever it comes across?
Yeah, what I recommend is getting closest to the site of injury.
Okay.
So my future son-in-law had chronic knee problems from all the sports he played. And within 6 weeks of the protocol, he's 70% better. He's out there in Venice Beach playing volleyball with some gals from Victoria's Secret. So I didn't know if it was the fact that his knees felt so good or they look so good. So
yeah,
so
it's a combination. You have to have.
I think it's a combination. But I was surprised because he didn't have a recurrence of his increase in his pain in his knees the following day, or at any time after. So he was on it for 2 weeks on, 2 weeks off, 2 weeks on, and then it's going to probably go back and do it again, see if we get 100% resolve with the peptides.
Yeah, I've used both of those peptides. They're both very effective. BPC 157 in particular, I noticed, really rejuvenates gut health.
Yeah, if you take the BPC 157 injectable, you use it for tendon ligament related stuff. If you take it by capsule, it helps with a regeneration of the gut. My daughter monitors the xylin or zeatin or something. It's an enzyme that indicates there's leaky gut. So she'll monitor that protein to see that it improves, and it's the oral BPC 157. Well, if you look at where does BPC 157 come from, it comes from a big protein called peptide, which is a gut peptide, and it's a snippet of that peptide that's the BPC 157. So it's really crazy, and it's, I think, 15 amino acids is what BPC 157 is. 15 amino acids.
Yeah.
So it's a short peptide. You know, growth hormone's 191 amino acids. And there's a AOD, you know about AOD 9604, which is a piece of the growth hormone molecule or peptide chain protein, which cuts out body fat, mobilizes body fat. And then there's the new one, what's that? Segapeptylin or which?
Yeah, that's in the mainstream media. That one's out there.
Yeah, that's the diabetic one that shuts off your appetite.
Right.
So you lose weight by shutting off appetite. And then there's the 5-amino 1MQ, which is a capsule, which if you do diet, you can lose up to 7% body fat within, I think, 3 months or 6 months. Yeah, 5-amino 1MQ. And let's see, and it basically in some of the literature says you don't have to change your diet. But if you want to get that 7%, having a good diet, you know, conscientious diet where you're not eating, you know, pizzas and having Haagen-Dazs chocolate chip or Ben & Jerry's fish food. I only know these because I read labels. I never eat them.
Some of the growth hormone increasing peptides I found to be very effective for stubborn body fat. The CGCs are CJC 1295, ipramorelin, that combo. There's a new one, AOD 1964, I believe.
Yeah, that's the one, 9604.
Yeah, 9604. Yeah.
That's the one.
Those you just find that you have a little bit of, let's say you have a muffin top or love handles, you just find, whoa, those are getting a lot smaller. So there's certain stubborn bodies, it just helps mobilize in certain stubborn areas.
Well, anything that increases growth hormone production, those are all the secretagogues, the ipramorelin, ceremelin, the CJG, and all those things. They increase growth hormone, and within the growth hormone molecule is the AOD, which mobilizes body fat, so you lose it.
Right.
Yeah, that's one of the things, you know, I've been using growth hormone since 1997. So, yeah, it's one of the things that I've seen over the years is when I'm on it, love handles like disappear, abdominal fat disappears.
Right. Now, with the IGF-1 LR3, is that something that should be used short-term usage, or are there benefits of using that for more prolonged periods of time, just for the workout recovery, the increase?
Yeah, it's a great question, which takes us to some fundamental issues. The fear that growth hormone causes cancer.
Right. That's
right. The fact that growth hormone is perceived as causing cancer is not true. It's a myth. And the reason why it's a myth is because growth hormone produced by the pituitary goes to the liver and turns on 10 proteins. 7 of the proteins are the binding proteins. IGF-1 binding protein 1, 2, 3, 4, 5, 6, 7. 7's a new one. Binding protein 3 and 4 have been found to be anti-cancer. So when you use growth hormone, you turn on the production of the liver, by the liver, of binding protein 3 and 4. If you use IGF-1, you don't get that.
I see.
So you want to use growth hormone more so than IGF-1. So the question is, where does the IGF-1 come into play? Healing, repair. And why is that? It's because IGF-1 produced by our body has an 8 to 10 minute half-life. The substitution that happens in the LR3, I think it's lysine 3 position. Don't quote me, but I believe that's what it is. It changes it from an 8 to 10 minute half-life to a 16 to 18 hour half-life. So what's the benefit of IGF-1 in terms of muscle repair, muscle healing, repair, and growth? It stops another hormone called myostatin. Myostatin stops your muscles actin and myosin and repair from being done. So if you're in the gym working out real intense, you want to accentuate not loss of muscle, but building of muscle. Okay, you want to use also L-glutamine along with it, some carnosine, which will help. So if you're in surgery, you have cutting of the muscle, you want to help with its repair, you want to use things like growth hormone and IGF-1. You want to use things like BPC 157. You want to use things like thymosin 4 beta. Okay, and this is what I'm seeing in our population, where they're getting on these things and having impressive recovery after orthopedic surgeries, where they're recovering, where their doctors are saying to them, dude, well, he doesn't say dude, but he says, you've healed, 50% greater. I mean, in one of the ESPN Outside the Lines, I think it was in 2006, one of the top orthopods for the sports world in Beverly Hills was talking about how rapidly our patients responded after surgery. He said they healed in 50% of the time, 50% faster, so in half the time. And that's because the healing nature of it. So the question is, why wouldn't everybody want to get on something that could help improve their healing? And it's short-term use. So you use the IGF-1 for 2 weeks on, 2 weeks off, 2 weeks on. So for 4 weeks, you're on it. We did in some of our healthy, strapping, healed veterans, we put them on to a month straight, and their workouts and their recovery for that month they were in the gym was phenomenal. They made gains like they never had before, and they didn't have the downside of muscle fatigue and achy muscles and so forth,
right?
Because it helped them with repair. So peptides are really neat. At my website, I have a peptide book that was written by Dr. Lee, Edwin Lee, who's an endocrinologist in Orlando, who wrote this very comprehensive book that takes you through each one of the components. And I'm asking him to write a new one because so many new peptides have come out. You think you have it?
I bought that off of your, I do
Yeah.
have it. I bought that off of your website. This is it. I mean, anyone interested in peptides, this is really good because it's very comprehensive. It's easy to read. It's not overly technical. It's just about 120 pages.
It's normally a $42 book. They can buy it for $20 off my site.
Okay, good.
Yeah, he did a great pricing, which I just wanted to pass on because I was getting so many people wanting to have consults with me about peptides. I said, read the book. Read the book. It's right. It's made for a knowledgeable consumer. Okay, that's who it's made for.
Do you have any experience with kisspeptin as a way to increase natural levels of testosterone?
It's funny. I just started reading some of the literature on it, on the kisspeptin.
Do you use it with any of your people right now?
No, I haven't done. What happens for me to recommend anything, I have to be well versed. I have to be read in on all the stuff. Look for the pros and cons. Look for groups of people who have already used it. Talk to their primaries about their experience with it, so that I have a reference point. Okay. Otherwise, I'd give everybody everything. Because this.
Well, that's important because otherwise, if you're taking too many things without having a clear idea of why you're taking them, then now how do you know what's doing what at this point? You're taking 10 different peptides at the same time, and maybe 2 of them are providing most of the benefit, but because you're on 10, you don't know which ones to concentrate on. Taking 10s, you don't know which 2 are doing the most benefit.
Yeah, we have people who come to us who have read the literature, but the literature doesn't define for them what combinations or which one they should focus on. So when they come in, I basically tell them, let's stop all this stuff, put it in the refrigerator, and we'll come back to it after we've done your labs. And then, their 20-page history report that they give me, they fill out for me, go through that, find out, historically traumas and so forth and so on. And then we'll construct a current protocol. And as you said, a a lot of things isn't necessarily a good thing. It can be counterproductive.
Right.
So we look at things that do counteract each other, and less is more. Always less is more. We use small dosings of testosterone and let it build up into the system, because if you get too high, you get negative effects. People don't, realize or see the literature that I see, or see the thousands of data points that I see, laboratory data points, where low level of testosterone, free testosterone, can cause elevation in cholesterol. Too high of a level of free testosterone can cause an elevation in cholesterol.
Right.
Too high of DHT can lose the benefit of wound healing. It's in that optimal window that we need everything.
Yeah.
Some guys develop panic attacks, agitation, irritability on high dosing of testosterone because they have the biochemistry to increase a chemical called adenocyclase in their brain, which is like methamphetamine, which causes them to become hyper, agitated,
Right.
aggressive. And I don't see it often, but it happens. And you correlate it. You see their high levels of 20, 30. I had someone in their 30s of free testosterone, and we want it between 15 and 20. One of the meters is if they're given an aromatase inhibitor, it's because they're being given too much. Their body is telling them, look, you give me testosterone, it goes a little bit to estradiol, it goes a little bit to DHT, it hopefully stays a lot like free testosterone. And if the equation is off, I'm going to generate more sex hormone binding globulin, and I'm going to have, bitch tits for you.
Right.
So what you need to do is lower the dose. It's not more is not better.
Right.
And you
Right.
saturate the receptors. If you saturate the receptors, you got free floating testosterone that gets converted by estradiol synthetase to estradiol, or 5-alpha reductase increases, or estradiol and DHT increase the production of sex hormone binding globulin. Free testosterone drops it. So it's a balance of those things. And that's one of the, another fallacy is that sex hormone binding globulin steals free testosterone. It doesn't. It has its own receptors. Sex hormone binding globulin and androgen on the cell membrane has its own receptor. It uses genetic pathway.
Isn't sex hormone binding globulin a transport hormone as well that takes testosterone and other hormones to areas to be utilized?
Yeah, it's part of a STAT receptor, which is a signaling receptor on the cell membrane. What happens is you've got the AR, you've got the androgen receptor sitting on the cell membrane, testosterone hooks up with it, sends a signal, and that signal creates change in our genetics. Increase actinomycin, increase protein, increase this hormone, dropping cytokine, increasing cytokine interleukin 10, which is anti-inflammatory, dropping interleukin 1, 1 beta, 6, and tumor necrosis factor alpha. So testosterone is incredible at dropping inflammation. That's why it's so important in our treatment protocol, because it drops, and that's why you get a drop in depression, because it drops the inflammation. You drop the inflammation, you improve serotonin production. You improve transport from within the nerve to outside the nerve. These little synaptic vesicles is what they call it. So the norepinephrine, epinephrine, serotonin that's in what they call the presynaptic neuron before the cleft, before the gap, and it gets locked in there, it can't get out. So you need to correct the chemistry so it can get out and do its job. Stop the depression, improve connectivity, so depression goes down, stabilize agitation so you're not anxious or panic attack. So
with testosterone, how much have you noticed people improving sex hormone levels with, let's say, just your brain care supplements to the point where they don't need Clomid or TRT? Have there been people that had, let's say, low levels of testosterone and
yes,
that had pretty serious improvements where you didn't even need to do exogenous supplementation?
That's great. We have a small population where they had 2 to 3 times doubling and tripling of their baseline luteinizing hormone and testosterone level. That's how we knew that their inflammation was being addressed. Okay, So, and I did have a major failure. It was a 43-year-old who, between the ages of 33 and 38, 5 years, he was on 200 milligrams of testosterone cypionate every Sunday. And he was on the testosterone when he came to us, and I had him stop it so we can assess him or modify it. His testosterone level, free testosterone, dropped below 1, and his total testosterone dropped below 2.
Wow.
And we tried for 6 months to turn his system back on. His system was gone. And it's because of what he did for that 5-year period. He kept on testosterone, and it shuts down the loop. Shuts down the hypothalamus, pituitary. It's the gonads say, hey, you got lots of testosterone circulating in your system. We don't need to function and make testosterone. And what happens is they atrophy, just like a muscle. You spend years building up your muscle, and then you stop doing the exercises, and your muscles atrophy. And they're flaccid, they're hanging.
Right.
And you can rebuild them, but in the biochemistry of the brain, it's gone.
Yeah.
Because it's gone on 3 different levels. So unfortunately, this guy at 43, he was 42, 43 years of age, he's stuck on injectable testosterone.
Right. Right. That's one of the things people don't take into account when they start a TRT protocol. They go, or especially when you're really young and you haven't exhausted other arenas. Let's see if we can ramp up your own production before we go to that route.
Correct.
So that should be the final step you take, not the first step you take. You've did other things. Okay, we tried Clomid, we tried lowering inflammation in the brain and elsewhere. You're still not responding. So rather than have you just feel like crap for the rest of your life, let's put you on a TRT protocol. And when someone at that point, if someone at that point says, okay, do I have to be this on for the rest of my life? No, you can feel like crap for the rest of your life too. That's your other option. But I think when people reach a point where they just feel so terrible, they don't care if they have to be on it for the rest of their life, because they know the alternative. The alternative is you feel terrible, suicidal, no sex drive, no zeal for life, just beaten down for the rest of your life. Or you take an injection and you feel great for the rest of your life. It's a
Absolutely.
point.
Yeah, and it's this stepwise progression that we've been doing since 2014. Prior to 2014, testosterone was flowing out of my own pores. Okay, so what happened was in 2014 was the first year of the 3-year veteran study on clomiphene citrate as an alternative, because the DOD had put a squash on dispensing to any active people testosterone, and also the VA for the veterans was pulling back on their writing scripts for injectable testosterone because they didn't want them to be agitated and a threat. So we started on clomiphene citrate and looking at the best pattern. So the pattern that we found was 50 milligrams every 72 hours. Now it's every 72 hours at nighttime to increase erections during the night.
Right.
And that's from some of the work from Dr. Abraham Morgenthaler from Harvard, from Boston Med, the guy who coined the frame low T syndrome, and talked, in lectures that I took from him about how important estradiol is in libido. So if you nail estradiol by thinking that it's a bad thing, you're going to have influence, negative effect on a whole bunch of systems in the body, libido being one of them, blood flow being another, growth hormone production being another. So the program starts off with clomiphene citrate, and we start them on 50 milligrams every 72 hours. 3 months later, we do the first waypoint testing to see how they're doing. And if their luteinizing hormones are proportionate to testosterone, we're great. And that's the pattern, the major pattern that we see. And once we see that their body is responding to the Clomid, I'll offer them the next step up, which is called the hybrid protocol. The hybrid protocol is a combination of Clomid with a low dose, 40 milligrams every 72 hours of a blended testosterone propionate and cypionate. And I've had guys say, man, that was it. That's what did it for me. Clomid, they were doing well, but when you added a low dose of testosterone, they said, that's it. And I've had people who said, that's it, but I don't like injecting myself. I was doing really well with Clomid. Go back to it. Okay. So the combination of clomiphene citrate every 72 hours with an injection of testosterone, 40 milligrams every 72 hours, is the hybrid protocol. And I've had people who go onto the program say, hey, doc, of all the docs I've been to, you're the only one that gives me Clomid with my testosterone. Everybody else gives the Clomid or the beta HCG after a cycle. And I said, yeah, think of it this way. You get a Porsche. You get into the Porsche, you drive 60 miles an hour straight into a wall, and then you put your seatbelt on. Okay? So you get to choose which way you do it. So we put them on it. And so what we monitor while they're on injectable testosterone is their luteinizing hormone level to make sure their luteinizing hormone still is in the active level and not inactive. They're inactive. You see it on blood tests when it's less than any number that the laboratory says. When it's less than any number that the laboratory says, it means you're not producing any. You shut the system off. Right. You need to have some vestige of luteinizing hormone being produced to stimulate the brain, the hypothalamus, the pituitary, and the gonads, because it's that signal, loss of that signal, that tells the Leydig cells that make testosterone, hey, turn off, go to bed, don't come back. Okay? You're done. We don't need you anymore. And that's the problem. You need to keep a back, what do they call it, a safety net, or right. Something to a backup plan. So what happens is the guys that are on the hybrid protocol, after being on testosterone for a year or 6 months or whatever, 2 years, they said, hey, I want to go on to a vacation from injections. My legs are hurting me, my stomach's hurting me, my arms, my butt, whatever. Or else I just want to stop. I said, fine. Stop the testosterone, go back up on the Clomid from every 72 hours to every 48 hours for 1 month, and then drop back to every 72. And if you don't feel good, come in, we'll do a quick test. We'll see where your LH is. We'll see where testosterone is, your estradiol, and so forth. Majority of the people respond very well. So they have kept the integrity, and I call it biological integrity. We keep their system running. Same thing happens with growth hormone. If you use growth hormone all the time, it'll shut down in 48 hours after 2 shots of, and this is in the literature, after 2 shots of growth hormone, your production, your innate production of growth hormone drops by 40%. At the end of 30 days, you're making 0 of your own growth hormone. All the growth hormone is coming from your injection. So what we have is a hybrid protocol for secretagogue. So we put them on either dinotropin or secretropin, which is an oral secretagogue, at bedtime, along with their injectable growth hormone in the daytime. So what happens is they need less injectable to get the same level because it's additive from their own production.
Right. That's the key word right there, additive. I mean, these are very nuanced approaches because there's a lot of bad advice out there where it's often don't take Clomid and testosterone at the same time because now they'll cancel each other out. And that's one often.
Yeah, that's such bullshit.
Yeah, it is. It is. What you're saying makes the most sense because now you're getting the best of both worlds. You're taking something that augments your own production so that you keep gonad function and so forth. And then you're taking an exogenous source that's additive now. So let's say that Clomid gets your levels to a pretty good range. Now a small dosage of testosterone takes it up a little bit more, and now you feel fantastic. You feel at this really good, steady range. And I think with 40 milligrams, what you're saying, are you able to use a much smaller needle, such as an insulin needle?
5/8 of an inch, 25 gauge needle. Yes, I do have some people who try to use the 30 gauge or 29 gauge 5/8 of an inch needle. The 30, because it's, see what oil they're using. They're using grapeseed oil. It's a little bit more viscous, and therefore the 30 doesn't work as well, 25. And, just pinch the skin and wiggle it, and you don't feel the needle going in. And you can use abdominal approach. You can use above the quadriceps. You can use gluteal. Some people have someone inject them deltoid.
What about low dosage of testosterone cream, or are you not a big fan of using the cream?
I don't use creams for a couple of reasons. What happens is Because we have 5-alpha reductase in our hair follicles. When you put a cream onto the skin, it will advance the conversion of free testosterone to dihydrotestosterone. And since dihydrotestosterone upregulates sex hormone binding globulin, we don't want that on one level. On another level, we want free testosterone because it can get into the brain. DHT does not get into the brain. It's made in the brain from free testosterone. And you need the DHT because in the literature in neuropsychiatry is that it affects the startle response, the fear response on the amygdala, which is part of the limbic system, the emotional center. So they found that DHT is very important for help down regulating panic, fear. So you can look up, on Google Scholar, you can see testosterone and fear, and you'll pull up some articles on it.
So a better approach to increasing DHT in the brain then is increase your free testosterone levels.
Correct.
And then converts the DHT in the brain.
Right.
To trying to increase DHT systemically and hoping that it goes to the brain and elsewhere it won't.
It doesn't. Yeah. Bound testosterones don't get into the brain. So, right. And the testosterone through osmotic osmotic gradient gets through the BBB, the blood-brain barrier.
And then they probably have way more sebum production, so you're more likely to have skin issues, acne, and so forth. I think.
Yeah. What happens is DHT directly stimulates the pilosebaceous gland. Sebaceous is sebacum, which is the oil. Right. So DHT will cause that. DHT is associated also with enlargement of the prostate, increase in PSA. Benign prostatic hypertrophy is directly under the guise or the direction of DHT. So you want to keep DHT low so you don't get an artificial spike in your PSA level that freaks you out and you think you have cancer.
Right.
So, so in the past, we've monitored PSA and DHT levels, and we see that they parallel each other. DHT goes up, PSA goes up. DHT goes out, PSA goes down.
Right. I like your approach because it seems that a combination of addressing brain inflammation, using something such as Clomid, which ramps up your own production of testosterone, and then a little bit of exogenous on top of that when needed. That's a pretty nuanced, sophisticated approach as opposed to, okay, you either use Clomid or you use testosterone. Yeah. And then there's so much bad advice with Clomid saying, no, Clomid's only for after a steroid cycle or if you want to get off TRT, you don't use it on. It's amazing how that kind of flawed information, antiquated way of thinking just keeps getting proliferated, where many say that you either just get on TRT, forget about Clomid.
Yeah. Well, it's in our job as healthcare providers is to provide health. And if we give a product that we know is going to disrupt the biochemistry of the body, how is that giving them better health?
Right.
And also there's always a price to pay. Yeah. You just want to pay the least amount.
Right.
So it's about thinking ahead, proactive in setting up programs. And, we've been doing this for a while, since 2013-14, this hybrid protocol. And it made sense. I mean, in the past, I used HCG. Back in the 90s, early 2000s, I used to see a lot of guys for a safe harbor hormone replacement protocol. And we controlled the dosing of products because everybody thinks that more is better. They want to see the testosterone exuding through their pores before they believe it's good.
Yeah.
And I've had cases where they yelled at me and I said, okay, here's 4 syringes of 60 milligrams of testosterone, take a shot every Sunday, and then come back in 5 weeks. The guy came in and said, man, if I didn't try this out, I wouldn't have believed it. He gained 5 pounds of lean body mass. His workouts were great. More is not always better. And the only way you know that is by doing less, not starting off with more, because once you start off with more, you've now biochemically altered them to an addiction for a higher level.
Right.
Because there is a cerebral effect of it.
Right.
Yeah,
you just get used to that higher level, so now you have to keep upping it, similar to a drug addict. Start off, you get high on a certain dosage, And then over time, you have to take more to get that same effect. And then you get to the point where it doesn't matter how much you take, you still don't get that effect.
Yeah, and it takes about 3 to 6 months for the guys who come in on 200 milligrams a week of testosterone to get them on their Clomid and to start tapering them down from they're on Clomid instead of 200 milligrams, they're on 100 milligrams a week. And then what we do is start tapering it down to the level that we want. And they respond as long as you do it nice and I won't say slowly, but evenly. Okay, based upon how they respond, how they're feeling. Hey, I'm feeling great now. Okay. In the beginning, they didn't feel great because it was such a change. Hormones are very unique in that you can make small changes and it seems like the world's changing. I mean, very small modifications and it impacts us so intensely. So you have to go lightly. So we go up and down by 10 milligrams. So they might be on 40 milligrams and we go to 50. Then we go to 60. I have very, very, very few people who are on 100 milligrams a shot. Very, very few. Most of them are on 30 milligrams because what happens after 4 to 6 months is they start reservoiring their testosterone. So you're giving them the 40 milligrams every third day, and 4 to 6 months later, they've got levels that are super physiologic, but you haven't changed the dosing. And I ask them, did you change the dosing? And also, to be consistent, we always draw the blood on the third day, meaning that if they took the shot on a Monday and they're supposed to take a shot on Thursday, we'll have them hold the shot on Thursday and they'll take their blood work. And then after the blood work, they'll take their injection. And that gives us the trough. So we go for a trough level that's just within our 15 to 20 because we expected to dip. It's normal. But a majority of these people being tested, there's no consistency in when blood testing is done. They're all random.
Right.
So how does that tell you anything about how well the dosing is doing if they're all random?
Right.
You have to have a methodology. You have to be anal like me, okay, in setting up these things where the variables. You try to minimize variables. Oh, your level's low. Why is the level low? I don't know. Well, you didn't take a shot since a week. Maybe that had some. Oh, yeah, maybe. But you want to know, oh, geez, you've got such high levels. When did you take your shot? Yesterday. Oh, you're supposed to take it 2 days. I forgot. I forgot to take it. So you can see it in the patterns. So, when things are higher than anticipated, you ask them, when did you take the shot? I took it yesterday because I forgot to take it 2 days ago. That's it. And that's how we've been running things for, 20 some odd years and just getting better and better because the science, teaches us how to be more critical in how we approach this. Unfortunately, there are the majority that just go and do TRT, HRT and don't have the deep dive into it. And that's my goal is through all the educational formats that we have is to try and provide this science. That's the reason why we started doing the 1 minute lecture that the last one was 1 minute and 38 seconds. But it brought up the two key reasons for, why people can have low testosterone without it being a deficiency.
Right.
It's a mechanism. It's a biochemical mechanical problem. It's not a deficiency.
Right.
In the sense of, hormonal deficiencies from dysfunction of the gland.
Well, hey, this has been great. It's always a pleasure talking to you. And I want to just end with letting people know how much great work you do with the Warrior Angels, because not only are you excellent at proliferating incredible hormone optimization information, you do a lot of nonprofit work to help soldiers, in particular veterans that are dealing with these brain traumas. And I think often in America we hear, oh yeah, support the troops, tell the troops how great they are. But I think it's a travesty that we have so many veterans with mental health issues. I think it's reprehensible that we have any veterans that are homeless on the streets.
Yep.
As a country, we should be taking care of these folks that put everything on the line for us. So I just want to applaud you for all the great work you do with veterans.
Thank you.
Not only are you doing an excellent job educating all of us regular folks on hormone optimization, But I think what got you into this with so much passion in particular is helping veterans feel better. And it must be extremely gratifying for you when you take someone who is suicidal and has depression and they're just being forgotten by our society. And you're able to just, someone like Andrew, for example, who just night and day, just turning his whole life around.
Yeah. I've been very fortunate in having, in 2009, been drawn into the needs of our military. And then in 2014, 15, meeting with Andrew, who had a turnaround that was just incredible. So Andrew has a 501c charitable organization to help with the military. I'm self-funding. All the products that I do, the lectures I give, everything that we sell generates funds to help offset costs for our veterans. And we've been able to drop the cost significantly. My goal is to have it so that it's free to get the laboratory work, get the assessment, and so forth. And they just have the responsibility of the treatment protocol, which is, through our website for our veterans, is reduced also. And that's it. So got to stop our goal is to stop the suicides, and Andrew and Warrior Angel Foundation and I, and now some of the other organizations that we're expanding into or working with have the same goal. So.
Right. Oh, about to fall over here and break my neck.
No, don't do that.
The other thing is when people buy your products, they're also supporting all of these causes because you invest some of the profit from the product sales back
about 60%.
How much?
About 60%.
60%.
60%. Yeah,
wow.
I have one product that generates my living expenses, and then all the others. I just launched my new online educational series for TEI. Every time someone buys or purchases the online training, it adds another $250 to a veteran's account. So it was originally $2,500. It's now $1,000. My goal by mid-year is to have it down to $750 to $500. Some of the programs that we're doing to generate the software that I wrote to help analyze laboratory testing, the products that are on the millenniumhealthstore.com, which is, for brain health and cognition and so forth. You don't need to have had loss of consciousness or major head trauma to get the benefits of it. We have people who have had, they say they've had none, and their cognitive ability, their calm has improved because there's always some level of inflammation in the brain.
Right.
We all have it. Aging. I mean, the greatest developer or causation for non-traumatic inflammation of the brain is the normal aging process, because as we age, we accumulate more of the free radicals in the chemistry that creates the inflammation. So
and then
that's
you think
the issue.
how many of us have had some kind of brain trauma and just didn't really think about it. I remember the first time you and I talked about this, I remember all the times I went snowboarding as a teenager and crashed, and no one wore helmets back then. And I have some people that are a little bit more well-advised wear helmets when they go snowboarding. But back then, we used to slide on ice all the time. Boom, you hit your head, and you're like, oh, yeah, I feel a little bit off for a second, then you just keep going. Or you've been in a minor car accident where there was whiplash, or a major car accident.
Right.
And
yeah. So these are what we forget from birth, delivery, learning how to walk, learning how to roller skate, skateboard, bicycle, crazy things we do. I talked about jackass, jumping off of, I've jumped off my roofs in the past onto a trampoline, or a slip and slide, or, crazy things we do growing up. And we totally blank them.
I'm friends with one of the jackass guys, Chris Pontius. I'll have to link him up with you to have some. He lives out there in California. So I'll have to have him come in for a consult because I'm sure he's experienced some pretty bad trauma.
Yeah. 3 car accidents, martial arts for 8 years, things that we do. Ice skating, snow skiing, water skiing, you know, from the bump, 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 being in a truck on a country road for an hour and a half, you know, dun, 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 you know, what do they call it? Train track type of bouncing. And we ignore all this.
Right.
You know, we ignore it. But these are all contributory. I mean, we have guys who have only shot 50 caliber machine guns and developed the same thing as if they had been exposed to a blast trauma, IED, or what have you. The same thing. Or
we've been taught as a society to accept decline as well as an inevitability. Right. So also often you're going to be influenced by your immediate peer group. So if you're 45, 50 and you feel terrible and you're 30 pounds overweight and you have no sex drive and you're basically depressed most of the time, and everyone you know you're like, oh, well, this is normal. And that this decline has been normalized in the vernacular a great deal. I talk to people in their 30s. They think, oh, I'm 30 now, so I have lower energy. 30?
Mm-hmm. Yeah. Yeah. You start losing, you know, prematurely, you start losing your growth hormone, your DHEA-S, your DHEA, and your testosterone. You know, it's usually 14, what do they say? Growth hormone is 14% drop by the age of 30. Testosterone is 2% per year at 40. And that's all things being equal. But if you've had history of, you know, trauma that creates neuroinflammation, you're on a faster slope and you're dumping it. I mean, right. I'm in just awe at some of these vets that I see that they have levels of an 80-year-old.
Yeah.
You know, where it's like vapor. They're on fumes instead of having a nice solid. And most of the guys I'm seeing right now are in their mid to late 30s. And they've got levels that are, you know, 60, 70-year-old people.
Right.
Yeah.
So in essence,
and they're wondering,
you're walking around, you're in your 30s, but you're walking around as if you're a unhealthy 7-year-old.
Right. Absolutely.
And we're an adaptive species, so we just adapt to whatever happens and just normalize it, going, oh, well, this is my new normal. I think sometimes people forget what it feels like to feel really good, to have the exuberance of energy and enthusiasm. Sometimes maybe some people never had it, but I think sometimes people forget until they start dialing these things in and they go, wow, I remember this feeling from 15, 20 years ago.
Yeah, that's where the peptide PT141 comes in. You know about PT? That PT141 makes you have the libido of an 18-year-old.
Oh, yeah, it sure does. It sure does. Yeah. You want to talk about a morning erections? You take that a night before. You say you take that on a Monday night, you're gonna have morning erections all night, you know, into the morning, no doubt. Is that something that people can take regularly, or is it more for an event? In other words, could you take that 2-3 times a week just for the hell of it?
Well, I haven't seen anything that said you shouldn't take it more often. The side effect, you know, the most common side effect is nausea and vomiting, but a lot of people don't see that. I mean, I don't see that. Injectable versus nasally snorted. You know, injectable, you take it an hour before, take half the dose, an hour before you take the other half an hour before, you know, just subcutaneous, and it works. What's really bizarre, it's a melanocortin. You know, it's a pigment area of the brain that it works on. And I'm going, what? Yeah. So I'd love to be in the laboratory of the guys who define these things, you know? Yeah. It's just brilliant stuff coming out. But PT141.
I don't notice a tanning effect as much with PT141. Maybe because I mean I don't take it more than once a week or twice a week at the most. Maybe that's why. But the other one, melanotan 2, if you take that regularly, I mean, it's going to be several shades darker in no time.
Yeah. So you've used that?
Which one, the melanotan 2 or the
melanotan 2?
Yeah, I've used both. Yeah. Melanotan 2 I used a while back, but it definitely caused a lot for all the time. And the great information, as always, is one of the concerns with high dose vitamin D3 is that it increases calcification. And you made a good point in one of your newsletters, which I recommend everyone subscribe to, just sign up for your newsletter, is that often that's a problem with people that are just taking too much calcium supplementation in addition to the vitamin D. So you don't recommend, in just across the board, you don't recommend calcium supplementation, and then in particular, not with vitamin D3.
Correct. When we use average of about 10,000 in our patients because of all the benefits in the anti-inflammatory,
Right.
stabilizing the immune system, anti-cancer, cancer treatment. I mean, there are millions of articles of vitamin D as a cancer prevention product, as a cancer treatment product, for protection of the heart. I mean, since COVID, um, tens of thousands of new articles just last year came out, the benefit of the heart. So when someone is given a high dose of vitamin D, I tell them, look at three things. Don't take any calcium supplements. Don't use Tums because Tums are elemental calcium, and try not to chew on any drywall because of the calcium carbonate in it. And that's basically it. And when we do their laboratory testing, we monitor their vitamin D3 level and their calcium level. So if I should see an elevation in their calcium level, then I'll make comment to them that there is, some source, green leafy vegetables, or maybe calcium in something they're taking that they didn't see has it in there. Now, the relationship between K2, K7, vitamin K, we'll just say, and vitamin D and calcium is the fact that vitamin K will help to release calcium deposition into the lining of the vascular walls. So it helps to diminish the atherosclerotic buildup. Okay, so that's what they're focusing in on. As we talked about early on, it's the stickiness of the lining of the arteries, the intima, that predisposes you to having adhesion of the calcium on the wall. Remember, calcium is a Band-Aid. Calcium is used by our body in something called secondary intent or secondary repair, where calcium is used as a bandage. Classical findings are in someone with tuberculosis. The gumas, or the effect that happens in tuberculosis, the immune system starts laminating around the tuberculosis calcium, and it forms those gumas that we see on X-ray, signifying that there's TB. That there was TB, it's been walled off. That's how our immune system functions. You get a hematoma, you get hit on the calf, and you get bleeding. If you don't drain it, what happens? It ends up being a ball of calcification.
Right.
That then needs to be surgically removed. So the lining of the arteries, if there's any stickiness, the calcium will deposit on it. So if you have excessive amount of calcium because you're taking excessive amount of vitamin D, that can predispose you to increased deposition, and that's where the vitamin K comes in. So I don't use vitamin K, generally speaking, because I control and monitor their vitamin D and their calcium levels. And then once a year, I try to get our population to get an ultra-fast CT scan of the body. They get scanned with a thin knife scan, and it will pick up all the calcifications. In the heart, they'll see calcification scores, and there's a mathematical thing or calculation they do on calcium deposition, which is related to risk factor.
What's the name of this scan again?
It's an ultra CT scan.
Ultra CT scan, okay.
Ultra fast CT scan of the whole body.
Okay.
So I get it done every 3 years. There's a radiology department that I use in the Valley that gives our patients phenomenal pricing for it, and they get a disc and they get a disc and a report. So, and the report goes through looking at the neck, the thyroid, the mediastinum, the lungs, the heart, the kidneys, the liver, the gallbladder if you have it, I don't, the colon, and the spine. So it'll pick up your spine, and then it'll pick up your prostate. So it gives you a screen of everything. And the trained radiologist that we use, goes through it and looks for any abnormalities. So it's an overview. So every 3 years I get it done. So it's well worth the investment.
Definitely.
Through insurance, insurance will reject it as being unnecessary.
Well, that's the problem with insurance. It doesn't cover anything useful for the most part. So you have to take it upon yourself to do all these things. And that's the other thing that's problematic, is that people are trained to only get what their insurance will cover. They don't want to pay for anything out of pocket, but these things are so salient that it's worth the cost of paying for it.
Yeah, once a year,
Here, people will spend more
putting
money on their car than their own health. Often when I
coffee.
recommend things to people, I'll recommend peptides or different modules to people. They're always very price conscious of those things, but the same people will pay $2,000 a month to lease a car, or or spend money on their landscaping in their front yard before their own
Right,
health.
right. It's priorities.
Right.
That's priorities. And,
My grandfather
health.
my grandfather always said you can do whatever you want as long as you're willing to accept the consequences. And my retort to that is you can do whatever you want. Even if you're not willing to accept the consequences, you're going to have to accept the consequences.
Yeah.
It's not as if I'm not willing to accept those consequences. They just move on. They just go to the next person. No, whether you like it or not, your actions, you're going to have to accept the consequences.
It's yours, want it or not.
Right. Right.
Yeah, absolutely. People are funny. I mean, people are funny. I've seen my share of very funny people where you tell them what's wrong and they said, okay, what would you like to do? Nothing. Now I know. And then they have their heart attack. Okay.
Yeah. But I mean, you can't do anything with those people. You have to want to improve. How do you help someone who doesn't want to improve? You actually have to want to improve. You have to be in a state of, I feel terrible right now. What do I do to improve? And then you're someone who's willing to take those actions, as opposed to, I always say it's a big waste of time to give unsolicited advice. So for example, if you see someone at the gym and they're doing something correctly and you say, hey, let me show you something here, especially if it's a guy. Well, if it's a woman, she thinks you're hitting
on her,
which is probably true in 99% of cases. and if it's a guy, his ego gets in the way, and even if your advice is good, they're not in a place to hear it. They're not in a place to be receptive to it most of the time. So that's the problem with unsolicited advice, is that you're offering something that no one asked for, so they're automatically put off. I mean, it's basically the equivalent of someone coming to your door and knocking on your door, and maybe they're offering you something that you may actually think is useful, but just the fact that they're knocking on your door, you're already in an irritated state.
Right.
And
you reject them.
Hearing it. You're not conducive to hearing it.
That's called, I think, human nature.
Yeah, exactly. Exactly.
Yeah.
Well, hey,
so you
oh, sorry, go ahead.
Yeah, so you start off with the gal and say, look, I'm not hitting on you. I'm just going to offer you, if you want it, yes. If you don't, not a problem.
What my philosophy always is that I don't offer people advice who don't ask for it, but I'm happy to give advice when people do ask for it. So I had a guy come over who saw me deadlifting one time, and he asked me if I could take a look at his son's technique and offer any pointers. I was like, yeah, sure, I'm happy to do that. And every time I see his son, he doesn't just pick my brain for an hour, but he'll just ask me a couple of follow-up questions, and that's fine. I'm happy to help people. I naturally want to help people. I just don't want to waste my time. And I find that if someone's coming to you, chances are they're going to be receptive to the advice, or at least be open to hearing it.
Yeah, I can relate to that because I have a tendency to offer advice to people, and I watch as their eyes gloss over, as you said. Yeah.
Well, you're a naturally compassionate person, so you want to help people, but that you can always tell when it's just not being received. That's the problem.
That's right. Yeah, my daughter a couple of times has elbowed me and said, "Not the right person." Yeah. Says, "Walk away." Not the right person.
Yeah.
So, okay.
Well, hey, thanks a lot. Always great information. I'm going to put all your info in the notes below so people can check it out. I recommend people follow you on Instagram, check out your website, sign up for your newsletter, go check out your products. If you're interested in peptides, go get that book by Dr. Edwin Lee on your website. That's an excellent book for anyone who is just new to peptides and just wants to familiarize themselves with it. So again, I appreciate it. Happy New Year to you. I hope 2023 is a great year for you. And your work is always inspiring.